welcome to the NCG Koita Center for Digital Oncology regular webinars that we are starting now. So just to give you a background, the NCG Koita Center for Digital Oncology was set up last year, thanks to a very generous contribution from the Koita Foundation, which is funding this center for the next 5 years. So this is one of the verticals of the National Cancer Grid. I'm sure most of you are aware of the other activities that we do. But just to clarify, this will be a series of webinars that the NCG Koita Center for Digital Oncology will conduct every 2 to 3 months and cover various aspects of digital health as related to oncology. So today we have 3 or 4 topics which are just to update you on what's happening with the digital initiatives within the National Cancer Grid. First, we'll start with the NCG KCDO initiative on the EMR deployment. So what we did will be briefly described by Dr. Nikesh Shah, who's the CEO of the NCG KCDO. This will be followed by a brief walkthrough of the new NCG website. So some of you might have noticed that we migrated to a new website, which is hopefully more user-friendly and will be something that will be far more interactive as time goes by. Just to let you know that this is just phase 1 and we'll be expanding on its capabilities in the very near future. Third, we'll have an update on interoperability between different electronic medical record systems, including the Ayushman Bharat digital mission, which many of your centers might already be part of or be in the process of getting integrated. And for this, we have Mr. Kiran Anandam Pillai, who's a volunteer with iSpurt, which is a voluntary organization based out of Bangalore, which looks at large digital problems, including, for example, Aadhaar, UPI, the India Stack, Digital Health Stack, and so on. Kiran also worked with the National Health Authority for quite some time in the recent past. Finally, we'll have a demonstration of the iECO's platform, new capabilities for learning and development. And we are very grateful to the ECO group, both based out of New Mexico, as well as the India office for their continued support over the years. So without much ado, I'll hand it over to Nikesh, who will start with the first presentation. Over to you, Nikesh.
Okay. Thank you, Dr. Pramesh. So like Dr. Pramesh was saying, we just wanted to give you guys a quick update on what has happened since our last webinar. And the primary program that we launched was the NCG EMR initiative. And if you remember, we had spoken about the LEAP program or the Leading EMR Adopter program. And as part of that program, we had requested any hospital that is part of the National Cancer Grid that needs help in implementing an oncology EMR to approach us. And especially if you're a government or a trust hospital, we were also willing to co-fund the EMR implementation. And we've got a fantastic response. We've got over 20 hospitals that have applied. And so we're actively evaluating everyone's request and engaging with them to understand their commitment and the vendor selection process. So for those of you who are still waiting on a response from us, please be patient. We just have too many hospitals to go through. But that is being actively pursued. So we will get back to you in the next few weeks. That being said, if there are other hospitals that are yet to apply or are considering, please engage with us. Even if you decide to not pursue, at least the information will be very helpful to you. So you can write to ncgemr at gmail.com. But as part of that initiative, I also wanted to give you guys an update on what has happened post the empanelment of the 6 EMR vendors, right? That are on the website as well. We've effectively formed subcommittees to continue to advance our journey on the NCG EMR. And today we will have Kiran talk about one of those committees, which is the Interoperability Committee. So I'll let him give you more details about that. The second committee, subcommittee that has been formed is a subcommittee that is working on analytics and reporting. And that is led by Dr. Vipin Das. What that committee has been chartered to do is to standardize to a large extent the reports as well as dashboards that should be available to any hospital that is using oncology EMR. Because what we observed obviously is that there is a lot of customization around these reports. And then there's just a laundry list of reports that sometimes don't even get used. So our idea is to cover all of the operational, clinical, and financial indicators that a typical hospital or when you're running an oncology setup, you would need to run the show, and hopefully reduce the customization over time. Again, these reports and dashboards, once created, will be available in the public domain. So whether you are using the NCG EMR or not, you can take benefit of that and ensure that whichever vendor you are working with, or if it's a homegrown system, you can plug the same reports and dashboards. This is particularly important from a future standpoint, that when we get to a point where we start talking about a national cancer registry, this data can also be captured in a more systematic way and be fed into a central database. So much of the work that we are doing right now in many ways will be the foundation on which we will build many of the other initiatives. The third subcommittee is a clinical subcommittee, and it has three branches. We have a separate group that is focused on radiation oncology led by Dr. Amrut Kadam. We have a group that is focused on medical oncology that is led by Dr. Chandran Nair. And we have a group that is focused on surgical oncology that is led by Dr. Prathamesh Pai. Each of these groups are essentially taking the requirements that we had put out for the NCG-EMR and detailing them out in terms of the workflows that are required for radiation, medical, and surgical. So like we had updated that all of the EMR vendors that are currently empaneled with us, they continue to develop their products to become more oncology specific, while 70% of the work has been done in the sense that their existing functionality already provides that level of requirement. But the balance 30% are areas where we are essentially providing the subject matter expertise from our side. And each of these groups that I described have at least 4 or 5 different doctors from different institutions, so that we are not necessarily building something based on the experience at one organization. So it's a fairly cross-functional group. Again, that work, as it comes to fruition, I think in the next few weeks, will be made available to everyone so that you can all benefit from that. And the last update I want to give you is the broad roadmap that we are working on over the next 3 to 5 years. We've generally sort of categorized our thinking in terms of how we'll organize our work into 3 broad categories. And I'll not go into a lot of detail, but fundamentally, we have projects that are what we call as digital capacity building. And what I mean by that is building the foundation, right? Where you may not actually see a direct outcome as soon as you implement it, but it is very essential to getting to the outcomes that we want. So EMR is one example, right? Implementing an EMR in and of itself will not improve care, but it will provide you with the means that you can then leverage to improve care. The second area are projects that are focused on improving access and quality. Right now, we are actively evaluating a teleconsultation solution that will be customized for oncology. So just like we did the EMR process, we are doing a lot of due diligence on all the vendor solutions that are available in the market, figuring out what is our strategy if we wanted to really build a national scale teleconsultation solution. And then the third category is really driving research and innovation. So I spoke about the National Cancer Registry. Again, it's not something we are able to do today because the data is not organized. But those would be projects that would essentially focus on those areas that can then democratize access to a centralized database, which doesn't have to be patient data. It can be de-identified data. But anybody as part of our National Cancer Grid network should have access to that database who would like to do research in a specific area. So with that, let me quickly share my screen and just do a quick walkthrough of the new NCG website. So just so that all of you guys, this is the new NCG website. As you can see, the URL is ncgindia.org. So if you want to bookmark that, please do that. It has a slightly different look and feel than what the earlier website had. And again, I won't go into all of the menu items, but broadly, if you look at the top menu bar here on the gray, you have the About NCG, the guidelines, news and events. This is where upcoming webinars, like Dr. Pramesh was saying, these webinars are likely going to happen on a more regular schedule. We will put out a calendar here, so you can go to news and events to see whatever is the latest update on that front. Even the recordings will be posted here as well. Our intent is to do these every 2 months so that you guys can book your calendars in advance. The newsletter, the working with NCG, even the old website link right now is here in case there is somebody that wants to go back to the old website if they can't find something here. But we effectively moved all of the content here. Below that, you will see another menu, which is becoming a member. You have the NCG key initiatives. The hospitals and institutions, if I click there, it'll take you to all of our listing of NCG centers, which you can then filter by country or state. Let's say if I click Maharashtra, it will bring me all of the Maharashtra hospitals in one go. The most important part, I think, for this group is this one, which is the healthcare practitioners. If I just click at the sub menu, this is how we've organized all of the information about NCG that you will be interested in as a doctor or as a hospital. You've got the research resources here where you have Credo and the virtual research boards. You have the learning resources on the webinars and virtual tumor board, and even the NCG e-learning portal, which still will continue to direct to the NCG education site. All of the services in terms of our quality assurance programs, and then you have all the e-resources. So effectively, once you come to healthcare practitioners and the sub menu, this will help you navigate to wherever you need to be. Last thing, if on the homepage you scroll down, you will also see all of the NCG key initiatives quickly listed as these blocks. So if you click on any one of them, it will take you to more details about that. So let's say you want to go to the EQUAS program, and I click that. This will get you to the EQUAS program, and then from here you can navigate further. And then if you scroll down, I think some of the same menu items, the map of NCG centers and the news and events will appear. So please do take some time to browse through the website. If you would like any other changes or any content to be included, this is obviously going to be a dynamic site. We will continue to make changes and enhance the user experience. But we just wanted to take the chance today to give you a brief preview. So I'll stop sharing. I'm going to pass it along to Karthik. I think I'm going to switch. We'll do the echo overview.
Thank you, Dr. Nikesh and Dr. Pramesh, everyone at NCG and KCDO. It's just on behalf of Project Echo, we'd like to just give you an overview of this digital platform we have called iEcho. Of course, we are using Echo, the model, as well as our digital platform very successfully, at the NCG through the virtual tumor boards. But there's much more to Echo, which hopefully we would like to, explain to you a little bit, and then perhaps we can explore further collaboration with other NCG members shortly. So I'll just quickly walk through a brief overview of this digital platform we call as iEcho, and also a brief overview of the Echo model and how we look at capacity building. It's slightly different from typical, e-learning. So just look at a little bit about our strategy, what some of the functionality is, other aspects of digital platforms, and a little bit about what we are going to be doing in the future as well. So if we start about what is, Project Echo. Echo was started about 20 years back in hepatitis C, actually, in the United States by a founder, Dr. Sanjeev Arora, who's a gastroenterologist. And the idea was very simple. It was, how do we get community providers to present real-world cases to a panel of experts and just have, instead of like lectures and webinar kind of model, how do we make it interactive, and how do we leverage the knowledge which exists in the community, but bring it forward in a discussion environment through interactive case-based learning, and so that everyone learns from each other. And we call this all teach and all learn. And the intent is to create these communities of practice, which can be small groups of 20, 30 people, it can be large groups of hundreds of people. But the intent is to have discussion on cases with a little bit of didactic also thrown in. And over time, we've seen that this model is very successful in improving the capacity of frontline workers, health workers across the cadres, right? It could be super specialists, it could be, ASHA workers, nurses, physicians, etc. And the end goal is that community health is improved around the world. So the way typically it happens is community providers participate in these interactive sessions, they present their cases, expert teams provide their recommendations through what we call as guided practice. And over time, capacity is developed, experts contribute their feedback, participants also contribute their learnings. And the end goal, of course, is that the right knowledge is made available at the right place at the right time, right? We all can agree that knowledge exists, but the challenge always is how is the implementation of the knowledge happening in the grassroots level. And that's essentially what Echo tries to, work on. And about 2019 or so, we had this, sort of radical ideas. How do we take this model, which had been running for almost a couple of decades by then, but we wanted to improve our scale to reach 1 billion lives, right? For those of you who are familiar with Echo, like from many years before, it was basically we were just doing Zoom video conferencing, and you would track your data into a database. And from a technology and a platform perspective, it was very rudimentary. But we realized that if you have to scale this to impact a very large number of people, and we had chosen 1 billion, then we had to take this model, which is all about interactive learning and collaboration and guided practice and what we call as tele-mentoring rather than telemedicine. And over the years, this model had, led to the growth of this amazing community of over 1,100 what we call Echo hubs, which are institutes of excellence around the world who are using the Echo model um, to replicate programs in various focus areas. And we have more than 6,000 of these ECHO programs in all focus areas, including many in cancer, all around the world. More than 60 countries, we have hubs, and we have participants from pretty much all of the countries in the world. And also, there's a rich library of resources through didactic lectures, but also real world case presentations, research articles, best practices, which have come up through this network. And now we wanted to see how do we create a shared digital infrastructure which will support this. So essentially, how do we take this existing model and create a digital layer to allow this to scale? And the problem statement we were starting to see at that time was that partners were finding it difficult to run and manage programs, data management issues, siloed systems, and it was not really thought through from a digital first perspective. And participants also would essentially come to these Zoom calls, but outside of the Zoom calls, it was getting very difficult to keep track of cases, content management, certificates, and we wanted to see how do we combine these two use cases and bring it together into one cohesive digital platform. And we've been collaborating and learning from our colleagues at the Societal Thinking Initiative, led by Mr. Nandan Nilekani, of course, one of the visionaries behind India's digital transformation, behind Aadhaar and UPI and all these India Stack initiatives. Of course, we have colleagues from iSpirit here on the call as well. So the Societal Thinking Initiative is all about how do we, utilize technology to build public goods, like, for example, Aadhaar, which is open for everyone to take part in. It's not a closed system, it's an open system. How do we catalyze interactions in this network so that people can refer other colleagues into the network and make it more of a catalytic environment? How do we bring the agency and access back to our users so that Echo is not, or our partners are not dictating everything, but it is more organic and people are contributing their learnings? And also, how do we inspire co-creation so that if people are solving similar problems in a network, we want people to solve them together versus solving them in silos, right? And the end goal here is to distribute the ability to solve problems rather than distributing solutions, which is the traditional way of thinking, which is, hey, you have a problem, I have a solution, and I'm just going to tell you what to do. Instead, societal thinking suggests that the community knows how to solve the problem. We should give them the ability to solve that problem instead of solving it for them, right? So based on these learnings, based on our conversations with Mr. Nilekani and with our colleagues and our partners, everyone, we went around and built this digital platform we called iEcho, which is a cloud-based digital platform for the Echo movement. This is what it looks like. It is a web and app-based system. It is available on the web at iecho.org. You can actually just go and sign up right now if you don't have an iEcho account. And we also have apps on iPhone and Android. And our end goal is to make this as accessible and ubiquitous as possible. So it's available in more than 20 languages, all the major Indian languages as well as international languages, because we operate in all around the world, in Africa and East Asia and Latin America and US, of course. So our end goal is to have this one application or this product or platform which is connecting the entire Echo movement around the world. And our objectives behind iEcho development were a few. There were four of them. The first was, how do we reduce barriers to entry? How do we make it so that even if there's an ASHA worker in the field who does not speak English, does not have access to a laptop, how can she also take part in Echo? And technology should not be a barrier, it should be an enabler. Right? How do we make it easier to do Echo? So for our partners who are trying to replicate the Echo model, how do we make it faster, easier, and better so that they can accelerate it and get started very quickly? Third, how do we amplify the productivity and impact by automation and making it easier to do Echo so that you don't need to have all these repetitive and manual tasks, and we can track things like data and attendance and all these things automatically. And last but possibly most important is, how do we empower our community? How do we build community and do this at very large scale and do this around the world? And our end goal here is to create what we call as a trusted human network, which is empowered with technology to transform outcomes, right? So the technology is not the end goal. The human network we have here, of course, the NCG is an amazing human network, and the hundreds of these networks around the world. How do we create this trusted network and empower it with technology so that outcomes can benefit? And this is just the first step we're taking in that direction. There's much more to come. So I'll briefly just walk through some of the functionalities and features of what we have in this digital platform. Again, I won't go into too much detail today. We are happy to spend some more time with you later on to give you an overview. The first is what we call as program operations, which is when you are conducting, for those of you who have, done learning management systems or conducted capacity building initiatives, you will know that keeping track of what's going on is very, very hard, right? And it gets very complex as you have, hundreds or thousands of learners, and who's doing what and who's attending, who's not attending, what are the learning outcomes happening. It can get very complicated. So we try to make it as simple as possible. We give you the tools to organize your program into multiple cohorts. We give you the tools to run multiple programs in different areas simultaneously, and also handle scheduling and other areas to make it as seamless as possible, tracking attendance automatically. We also have communication tools, so giving you the tools to stay in touch with your community. So things like sending, at a basic level, sending email notifications to your participants, also sending WhatsApp text updates through automation in the system, and various other tools to build that communication between partner and provider. And content management and certification are inbuilt into the platform. So all of the didactic content, the cases, the certificates which you could provide, this could be CME credits or any other kind of certification. We automate the tools, and these are digitally verified certificates we have, which can be distributed to participants to make sure that they can continue their learning journey. We also have inbuilt data analytics. So these are data analytics focused, of course, not on the patient side, but these are focused on the learning side. So keeping track of metrics. So not only very basic level of tracking metrics like how many people joined and what was the attendance and things like that, but even more granular level, which is how is your retention trending over time? What is the knowledge level? How is that trending before and after you do echo session? Are people actually coming back again and again to take part in sessions, or is it like a one-off thing? So these insights are very important, and we have tried to make it automated and seamless so that instead of doing number crunching in Excel, the platform can do it for you, and you can basically focus more energy on building programs rather than doing Excel, right? And we also have data security, data privacy, and governance tools built into the system. We are a global organization. We run all around the world, which means we have to adhere to pretty much the highest level of data privacy and data security measures. So we have an in-house security team, and we also have governance tools within the system to make sure that personal information, of course, we don't store any personal health information, which would be patient information, but all the data that we have stays secure within our systems, and we have essentially firewalls to make sure that, for example, if you are running one program, then that data stays siloed off, and we reduce the risk of data privacy issues. And last again, but probably most important, is building community. So we have created tools to allow for participants to learn and discover from each other. So for example, if there is a learner, say in Tamil Nadu, who is interested in learning about, say, lung cancer, and they can go to IACO and just search for lung cancer, and all of the programs which are running in lung cancer, essentially from any partner within the NCG or within the world, of ECHO, they can basically register, take part of it, learn what is going on. They can also see user profiles of experts and see, okay, what have they been doing? And our goal is to basically bridge the gap between these different networks around. So that basically we are creating one unified network of ECHO and not creating these networks in silos, right? Got it. So I think I'll pause here. I know I've been going for a while, and thank you for the opportunity to present here. We are very eager to see how we can collaborate further. Of course, we have a very successful partnership with the National Cancer Grid and many VTBs running on ECHO, but we are hoping to take this forward in a big way. And I don't know, Nikesh, would it be possible for us to have Dr. Bhalla also just give an overview from his side right now, or I'll pass it back to you.
I think if it's a quick couple of minutes, it's okay. Otherwise, we'll run out of time. So,
Abhijit, can you please slide share? Bala sir, please, over to you.
yeah, we may not have too much time, Dr. Bhalla, because we have Kiran at 10:30.
So I think let us maybe next time we can do that. I think since
Yeah, I want to
Karthik
make
has
sure we look at-
mentioned to you about our partnership with the National Cancer Grid, and definitely this human network empowered with the technology, that is the whole crux. This iEco platform is helping us to provide the real outcomes. So I'll not go into any details. Maybe next time we can do that. No problem. Thank you.
Yeah, that'll be great. Just because I want to make sure we stay with the time. Thank you, Karthik. If there are any questions, you guys can put on the chat as well. And again, this will be recorded, so we will pass this along to other folks who may not have had the chance to attend. But with that, let me turn it over to Kiran to take us through the interoperability work.
Thanks, Nikesh. Good morning, everyone. As Nikesh was sharing, one of the tracks that NCG KCDO is working on is a interoperability track. And so what I'm going to just share with you a very non-technical, I would say, view today of what really are we trying to achieve with this interoperability track. So what is the problem that this track and this initiative is trying to solve? So as many of you know, I think a lot of data is already getting digital. Many of you have initiatives today to either digitize or have already moved to digital within your hospitals. And so the objective really that we have is, we also know today that a single patient in their cancer care treatment can go or seeks care across multiple institutions at times. And the question is, can we actually move the health data along with the patient so that they can get their best treatment? And so how do you actually move this health data, keeping in mind, as many of you may be aware, India just passed the DPDP, or the new Personal Data Protection Act last year, and that's going to soon come into place. So whatever we do in terms of movement of this data and in terms of use of data has to also be aligned with it. So the role of the Interoperability Committee in many ways is to find a technology solution and a practical solution that works in the Indian context for this particular problem. So how are we actually solving for this? As Nikesh shared, there has been a process by which several partners have been identified who have solutions that can be adopted by any NCG hospital for their EMR needs. And one of the things that these partners are being ensured is to make sure that all the information that's required for cancer or oncology specific will be captured by them. So we have started a working group primarily now along with these partners. And the intent is to make sure that we can have seamless data exchange if you're using any of these partner solutions. But I would also like to share that the way we are going about this is, even if you're not planning to use any of these solutions, but you have an alternate solution, as long as you have ABDM compliance is one of the key things, and you participate in the interoperability testing, your hospital software can also ensure that there is full interoperability. Now, the very first thing that we did when we started working is to identify what is the data that actually needs to be exchanged. So we had support from NCG experts, and at least we have now started for the top 5 cancers. We have essentially identified what kind of information ideally needs to be exchanged. And the next thing, of course, was to kind of decide in what type of documents would these informations be captured within the EMR, how they would be structured within the EMR, and therefore, when it is exchanged, the other party is able to appropriately incorporate and interpret that data in exactly the same way. So it's a fairly long list. There will be many, many pieces of information that we know. For example, we may not be able to fully structure in the early days. We are also looking at certain heavy images and files like MRIs, CT scans, and others, and also trying to make sure that interoperability means that if we require to exchange these heavy files, we will have a technical approach to also being able to exchange very detailed information for all of these types of cancer. So that's the part of the exercise that the interoperability committee is doing. The role of the committee in many ways is to make sure that each of the software partners that have been selected are firstly capturing all of the information that we require to track in oncology for various cancers in their software. So if their software does not currently capture a piece of information, they will be actually working to expand that to make sure that they capture that information. The second part of the problem that we are doing is to make sure that every partner is able to actually think of it as export, but every partner is able to export the data in a specified format on request from another system. So the way the interchange works, which I'll explain very quickly through the ABDM architecture, is that exchange only happens between two parties on request from one system to the other. So usually if the patient has gone from hospital 1 to hospital 2 will make the request asking for the medical history of the patient, and hospital 1 will have to share that with the patient's consent, and it will have to share it in a format that is then understandable by the receiving hospital. So that is the main objective of this program. And the requesting software has to be, of course, able to correctly organize this and present it to whoever is the treating doctor. So this is what we are trying to ensure. So we are, of course, doing this by leveraging the work that the government has already started in the form of the Ayushman Bharat digital mission. As many of you might know, this is a digital mission that creates digital public goods in healthcare. It is managed and operated by the National Health Authority. So one of the criteria in which all of these partners have been picked have been that they have already taken the effort to make their solution ABDM compliant, which means that they have integrated their solution with APIs that have been provided by the National Health Authority as part of the Ayushman Bharat digital mission. Now, the good part of the ABDM and the reason why we are also going ABDM is because ABDM's architecture is very nicely aligned with the Digital Personal Data Protection Act, or the DPDP Act, which requires any sharing and usage of personal data to happen only with user consent. So ABDM has what we call as a consent-based architecture, and in the consent, you can capture the purpose of the consent, the time period in which you want to have data, for the reasons for which you will use it, and so on. And so it nicely fits well, and making sure that we use this ensures that once we bring this to life, and whenever DPDP fully rolls out in the country, most of our solutions will already be compliant to DPDP. So how exactly would an interoperable NCG kind of a solution work? Basically, if one of the first things that will need to happen is if you have a patient and the patient goes to any of your hospitals, we will need the primary change. If you're looking at where would the change be, if you're already using a piece of software, the most of the change happens in only one area, which is at the time of registration. You will need to change your practices at your hospital to make sure that for any incoming patient, you're either actively asking them to share their Aadhaar. And as you might know, India just crossed about 50 crore Aadhaars being issued. So almost about a third of the population has Aadhaars now. And even if somebody does not have an Aadhaar, the National Health Authority allows your hospital to actually create or help them create an Aadhaar. You might be pleasantly surprised that this has already started to happen in many government hospitals. And typically, I work with several hospitals in Karnataka, and an OPD of 1,000 hospitals, we are finding that it's quite possible for us to get about 400 to 500 of them to actually create Aadhaars quickly on their phones if they don't have it, and then start sharing it. And for many others who don't even carry phones, we are able to create that using their Aadhaar card. So this is a core area of change that I would request all NCG hospitals that are already having any form of ABDM compliant software to start participating, because this is going to be very useful as we kind of go along. So now the expectation is that over time, all NCG hospitals will adopt and ABDM compliant software. So we would prefer, if you are implementing newly now, we would request you to talk to NCG KCDO and see if you can go with any of the selected partners, because that will make it possible for you to get a tested solution where it's tested for all the capabilities that you require for cancer, but also for oncology and also for interoperability. Now, when health information is created for the patient in your ABDM compliant software, one of the things that the software does automatically in the background is it essentially links all the health records with the ABHA that was captured during the registration. So the keyword here is linking. There's almost no health information is shared in the process. It simply says, hey, for this patient's ABHA, I am holding in this hospital certain health information. So that's a very key thing that you need to understand. So if the patient goes to a second hospital in the NCG network, and again, most important thing is to capture ABHA during registration, the second hospital can actually now request user consent for access to the medical history. And once the user approves, they can actually request for a copy of the records. And when a copy of records is requested, the records actually get shared outside of, it doesn't go through anything at NHA, it directly gets shared between the hospital, one or even multiple hospitals that may be holding records, and the requesting hospital. And it's the job of the requesting hospital to actually organize and present it. So all of this magic is done within the ABDM compliant software. And as far as the hospital is concerned, it's merely a process that you will need to adopt of making sure at the point of registration, you now start at a additional step, which is to request the patient for their medical history that is linked with ABHA. So, and I would like to repeat that the way this architecture works is that the ABDM system of the government actually cannot see any health data, and only the hospital that created the data or the hospitals to which the patient provides the consent gets access to all of the health data. So this is the core architecture that we are trying to use for exchange of health information between hospitals. And also we are trying to make sure that the content of the data that is being exchanged is interpretable by both the parties and both the softwares that are looking at the data. So how are we going to do this? We are actually setting up something called an interoperability testing between the partners. So we are asking each of the above partners to first make sure that the process I described in the previous slide is properly implemented in their software. And then we are actually asking them to generate data for each of the various data types I showed you earlier that we have got from the NCG experts. And we want to make sure that all of the data actually gets exchanged, can be exchanged between the two parties, and it actually works as expected between the parties. So this process is already underway, and our expectation is that it should be completed in the next 4 to 6 months. So which means in about 6 months from now, if you were to use any of this software, we can be pretty sure that health information can actually move between these partners. So what do you folks need to do as hospitals? So the first and foremost, as I already if you already have your own software, then you will need to embark on a slightly different journey, which is to basically make sure your solution first becomes ABDM compliant. If you are in one of those buckets, I suggest you to reach out to Nikesh or myself, and we can guide you through that process. And then once you are finished with your ABDM compliance, you can also start joining the interoperability testing so that your custom solution can also be fully interoperable in the NCG network. The other thing that's required, if you have already got an ABDM compliant software at your hospital, is first you need to register your hospital with what NHA calls as the Health Facility Registry. So you can just search for this online, and it's a very easy registration process. And if you can start issuing and collecting ABHAs right away during registration, two things. One, it will help you as the process of interoperability and exchange of health records becomes more common within the NCG network. But also, interestingly, the National Health Authority is right now giving away incentives So there is also a financial incentive, almost about 20 rupees per health record that you can get just because you're participating in ABDM. And so we expect this interoperability to start kicking in and many of the NCG hospitals to start getting benefits of it in the next few months. Thank you. Back to you, Nikesh.
Kiran, there are a couple of questions on the chat from Dr. Ramakrishna. I think the first question was, are there any system or software compatibility challenges for sharing digital images like scans or pathology? So maybe we can touch on the DICOM and the law.
Yeah. Yes. So there's definitely challenges in sharing very heavy, MRI, CT scans, pathology images. The first and foremost, Dr. Ramakrishna, is that whether this information is itself part of the HMI systems. Many times they are separate systems. They're sometimes sitting in PACS systems. So that is one part of the problem. The second thing is when we are actually doing the exchange, how do we actually exchange these files? These are problems that we have not yet fully solved as it stands right now, but our intent is definitely to solve for it. We do want to create an ecosystem or create a solution where all the information that doctors would like when they go from hospital A to hospital B is fully, exchangeable in the Indian context. But I think we would probably be able to answer this question after we have done some initial testing on the ideas that we have on how to exchange this pieces of information over time. In a few months.
Second question was, Kiran, what if the patient does not know his or her ABHA number?
Yeah. So it is actually possible for you to obtain an ABHA just by if they are even able to provide their Aadhaar. So most of the HMIS solutions that are integrated with ABDM already offer this capability because this is one of the requirements for ABDM compliance. So we are constantly improving, as you guys might have seen with UPI. Today, given a mobile number, you're able to actually discover the set of bank accounts that may be linked with the mobile number, making the process of setting up your UPI account easier. Very similarly, now NHA is also coming out with new APIs because when a patient comes to a hospital, one of the most common ways you search or you identify the patient is you start with a mobile number. So one of the things that NHA has also released are new APIs where given a mobile number, it will show you if there are ABHAs linked with that. So it makes it far easier for you to find the ABHA of the patient, even if the patient does not know their ABHA. So there is usually two types of groups that we see here. People who have downloaded a PHR app and have created an ABHA on it. Usually the awareness of them is pretty high because they use that to do something called scan and share to actually share their ABHA with the hospital. So we don't usually see a problem there. But for people who carry only a feature phone or don't carry phones, we do see a challenge with ABHA, and those ABHAs are best retrieved or dealt with using Aadhaar.
Kiran, next question, does anyone provide ABDM integration for hospitals wanting to do it? So they would seek their support.
Yeah. So there are two ways, like either, there is a site called abdm.gov.in/partners. So my request is, really, since all of you are part of the NCG, that's an exercise that KCDO has done. So please look at the 6 partners if you're going for a new software. But if you have an existing software and you're looking to get that to ABDM compliance, there are a couple of people who are trying to make that faster for hospitals. These are called ABDM connectors. My request is it's a little too complex for this. So I suggest that you reach out to either Nikesh or myself, and we will guide you to the appropriate partners so that we can help your technical teams in achieving ABDM compliance.
And there are a lot of nonprofits like the Clinton Health Access Initiative. They specifically are helping hospitals implement ABDM. So we could even put you guys in touch with those partners depending on your specific requirement, because there is a technical component to it and there is an operational component to it. But we'll be happy to help.
Yeah. So and I think Gurpreet has put in a comment from ThoughtWorks on FHIR. So Gurpreet, that's very the FHIR standards are usually highly technical for many of the hospitals to even understand the details. So usually we want to, we are dealing with that mostly at the interoperability level with the technical partners who are actually implementers for those kind of standards within their software. So I would suggest that we, if you're simply a hospital that's looking to get benefit of interoperability, you can talk to Nikesh and the team, and we will set you through a process where we can guide you on how do you get kind of started on that. Thank you.
Thank you very much, Kiran. Any other questions for Kiran or for the IICO team from the group? Okay, I think we are good to wrap up. We will, like I said, send you guys a link with the recording, even for those of your colleagues who may want to review the presentation. And like I said, just a reminder, we will start doing this more frequently. We'll put out the calendar and send you guys a note.
And for all the participants, you do know how to reach us if you need to. I'll put the NCG email ID on, and also maybe one of you can put in the KCDO email ID on. And if you want to reach any of us, either related to the NCG or to the KCDO, please feel free to write to us. Just to let you know that we are planning an NCG annual meeting, hopefully in person sometime in June or July this year. And we hope that many of you will be able to participate in that as well. Thank you all for joining, and look forward to seeing you all soon. Bye.
Thank you, everybody.
Thanks, everybody. Bye.
Thank you.
Thank you, everyone. Bye.